All right, so we'll go through the patient's journey for small bowel obstruction and large bowel obstruction today. So Jack, what are symptoms of a bowel obstruction generally?
So sudden onset abdominal pain or abdominal pain coming on subacutely.
Yep. What type of pain?
Often it's sort of like a crampy type
crampy.
pain. Yeah.
And what other symptoms do you get? Clark?
So you might get some nausea associated with that.
Yeah.
And it might develop. You might get some specific areas of the pain if it's causing some acute complications, or you might also get some.
So we've got pain and nausea. What are the
nausea.
clinching symptoms for bowel obstruction? The sort of lay down with their symptoms of bowel obstruction, Danny.
Bowel's not opening.
Yeah, bowel's not open. Good. No bowel action. What else?
Just
Yeah, well that's a sign. Yeah, distension. What else?
Loss of appetite.
Flatus.
Sorry? Yeah, flated. You see me on the water out. Have you pooed? Have you farted? And one other symptom.
I was going to say loss of oral intake or anorexia.
Yeah. Anorexia. But in addition to that, associated with this,
Vomiting.
vomiting. Yeah, vomiting. They vomit. Yeah. Okay, so easy. I'm not trying to trick you with a diagnosis. Just the garden variety bowel obstruction, pain, vomiting, haven't farted, haven't pooed. The signs are distension.
Tympanic to percussion.
Yeah, I'm not going to get too academic, but yeah, you can talk about bowel sounds all day long. The main important thing with the examination is what? Basically, are they sick or not? So, not sick is what?
Hemodynamically stable, non-febrile.
Whatever. Two clinches for not sick. Clark?
Maybe if they're able to mobilise. Maybe.
No, they both can mobilise. They're not paralysed. It doesn't cause spinal cord symptoms. Danny? They're sick when? Yeah, febrile. Yeah, could be.
They're sick when their obstruction is causing them to vomit profusely.
Well, they all vomit.
They all vomit.
Yeah.
Tense abdomen, so
Yeah.
Peritoneum.
Yeah, so examination, they're tender. Plus, and if they're worse than that, they're peritonitic. The not sick is the happy distended person. I've got vomiting, doc. I'm bloated. I feel like I'm 10 months pregnant, 11 months pregnant even. But they're not tender. They're usually, they're not soft, but they're not tense, they're not rigid, there's no peritonism. You can poke around in all four quadrants. They're just big because all their bowels is filled with gas and fluid. They're generally not febrile, and if they don't have a white cell count, that's great. So no white cell count, no temp, not tender. If they have a mixture of those two, maybe they're big, not sore, but they've got a white cell count, or big, no white cell count, but they've got a fever, then you've got to work out in your own mind, are they sick or not sick? And why is that differentiation important? Jack? Because the sick people get, what do the sick people get and what do the non-sick people get?
So is it to do with treatment?
Yeah.
Yeah, so sick people get a tube. Drip
Everyone gets a
cycle,
tube, because you've got bowel structure, everyone gets a tube.
They may end up with surgery.
Yeah, so
surgery.
the sick person gets an operation because you might have an encapsulated hernia, you might have dead gut in there, you might have a torsion in there that you've got to treat, you might have a closed loop obstruction. The not sick person gets to have conservative management for small bowel obstruction. Okay? Large bowel obstruction is a slightly different kettle of fish. Basically, everyone gets some treatment there. No one gets conservative management for large bowel obstruction, even if you're not sick. In large bowel obstruction, not sick versus sick makes a difference as to when you do it. If you're sick, you get an operation tonight. If you're not sick with a large bowel obstruction, you get something done tomorrow. But in terms of small bowel obstruction, not sick means conservative management, drip and suck, NG tube, IV fluids, rest. Sick means you get an operation because you might have dead gut. That's probably 80%. That's 10 to 20%. Okay. So you there are your signs and symptoms, investigations and diagnosis. What sort of things do you do to investigate?
So you
Jack?
mentioned bloods obviously is going to be
Yeah, bloods help.
but then I think imaging is important. So you could do X-rays, so supine and erect X-rays,
can,
or you
yeah.
could do CT.
But practically these days we get CTs now.
Mhm.
And what are you looking for on the CTs?
So looking ideally to see if there is dilated loops of small bowel, or large bowel obviously, and ideally you'd want to find if there's a transition point, and if there's one transition point, you might think that it's a mechanical obstruction.
Good.
And if there's multiple, or there's unclear transition point, it might be an ileus as opposed, or a non-mechanical obstruction.
Sure, excellent, good. And obviously you can work out if it's a small bowel obstruction or large bowel obstruction. You get an idea of the cause. If they've got a history of operations, more like adhesions, sometimes you look for a small bowel cancer or whatever. So good. And if you're managing conservatively, what is the sort of investigation, sort of treatment thing that we often give people? Danny?
Pain relief.
Yep, pain
IV
relief.
fluids.
Yep. But there's an
steroid
investigation thing that we give that often treats them as well.
Gastrography.
Yeah. And how's that work?
So they
What
swallow it, and you can do an X-ray, a double X-ray is they swallow.
Yeah. And what's the aim with gastrographin?
Is it to visualize a transition point or to visualize like the content going through the gut?
It's hopefully, admittedly, it's not a good test for visualization of fine stuff.
Yeah.
Going off the topic slightly, if you want to visualize the bowel well with a contrast study, barium's better than gastrographin, and you do a double contrast, so you get, you have air lining of the bowel wall on the other side. Gastrographin is mainly there to, it's an osmotic agent, so draw fluid into the bowel, and that's hopefully going to push through the obstruction, and it works in 80% of cases. In terms of gross information, it tells you whether it's worked or not. Either the gastrographin's still in the small bowel, or gastrographin's in the large bowel. So if it's in the large bowel, you've done the trick. If it's still in the small bowel, it hasn't done its trick. And so that's about the limit of information that gastrographin gives you, unfortunately. It won't tell you, is it an adhesion, is it a tumour that's causing the obstruction. So that's the sort of investigation treatment option that you have for small bowel obstruction. Now, even if you've got dilated loops of bowel, you've got your nausea, vomiting, distension, what are the differentials here? What's the main differential? You mentioned it.
Okay.
And
Yeah,
ileus.
ileus versus true obstruction. Okay, so an ileus is what, Jack?
So it's just basically with the bowel, due to some reason, stops functioning as a normal bowel.
Decides to be lazy, doesn't want to contract, doesn't want to peristalse, and that can be for all sorts of reasons: gastroenteritis, electrolyte abnormalities, being unwell for some other reason. You could be an old person with pneumonia, and that can cause a small bowel ileus or a large bowel ileus. Large bowel ileus is often known as, it's got an eponymous term. Large bowel ileus is often referred to as a pseudo obstruction, and not a true obstruction as the name suggests. The treatment we've sort of gone through, conservative management versus operative management if they're sick versus not sick. What else can we go and talk about? We've talked about drip and suck, giving the fluids.
Use of
Fluids is on
antibiotics.
another link, another YouTube video.
Mhm.
Won't go that. Antibiotics.
Antibiotics
Yeah.
indicated in the initial ED, workup.
What do you think, Clark?
I-
Generally not.
Uh-huh.
You give it for sepsis. So If they're the happy, distended, but not farting, not pooing and vomiting, generally not. You might give it here, depending on what you think the cause is. If you think they've got dead gut, then absolutely you should give it. If you think they've got a situation where there's an impending perforation of a bowel obstruction, then you should give it. So it depends on what you're thinking is causing the bowel obstruction. But as a generic thing, generally not. Yeah. And other things you have to watch out for, your distended abdomen, they get atelectasis, they might get pneumonia, something down the track. Obviously you need to do a septic screen if they have a fever for all sorts of other, the usual, septic workup causes, UTI, pneumonia, cannula infections. But for the small bowel obstruction specifically, only if something's going on here. We might talk briefly about large bowel obstruction treatment. The causes here are usually adhesional. Sometimes they're hernia, and then small bowel tumours are very, very rare. What are the causes of bowel obstruction for large bowel obstruction? Danny? Yeah, you can have volvulus, very good.
Cancers.
Cancers, yeah.
Masses.
Yeah, masses, which is almost certainly cancers. I mean, occasionally you get a diverticular stricture that can cause an obstruction, but yeah, masses, almost certainly cancer. So it's not adhesions, and unfortunately with these things, they're not going to settle with conservative management, so you need to do something about it. So what can you do?
So one option's a bowel resection.
Yeah.
For that portion of the gut.
Yeah, so
and then
the
the
resection
joint is
for mass
variable.
resection. Stenting is also an option, particularly if they're palliative and you don't want to subject them to an operation. And volvulus, what's the treatment there?
Lexi sig
Yeah, and what does that do? Or even a rigid sim.
or rigid sig. So basically, you just inflate air into the sigmoid colon if that's
Well, not
the area
not
affected.
quite. You inflate it so that you can see what's going on,
Yeah.
but you don't necessarily inflate it to treat it.
Okay.
The aim is just to get past the twist point, and when you get past the twist point, all the gas comes out and then untaught. So you want to untaught it by using a flex or a rigid sig, and then down track definitively, you might want to resect the affected loop so that it can't twist again, because it's redundant. Is there anything else we should talk about in terms of helping you write request forms or writing discharge summaries for these patients and just understanding where they're at? I mean, day by day, as they're getting better, obviously the things you ask are, have they passed wind, are they tolerating their food? You can adjust their diet by increasing the diet and spigoting the NG tube and seeing how much you suck out every day. Obviously, you've got to keep an eye on their electrolytes, make sure their potassium's in the right range, so that you can fix their pseudo obstruction. Even if they have a proper obstruction, when we fix that, there is no closed-stop ileus because we haven't we've ignored the electrolytes and stuff. All right. So that's a typical patient journey for large bowel obstruction, small bowel obstruction. Any other questions, queries wise?
No.
No. Okay, we'll leave it there.
Thank you.
Thank you.